You're watching Cetome TV. Knowledge is power.
My oncologist said a PET CT will not change how they treat us. What do you have to say to that? We hear this a lot.
Yeah, we really do. Well, I have some inside scoop here, which is that I know that over 80% of the time is the statistic that I've seen.
Right.
When a PET CT is conducted.
BC Cancer claimed 87.5 recently.
87.5. 87.5% of the time, when you get a PET CT, your treatment plan is modified, which means that, oh my gosh, no math, 12.5% of the time, your treatment plan is accurate.
Right.
Did you hear that? 12.5% of the time.
Not very good.
And even then, it's really, we're just talking kind of about location and grade.
Yes.
We're not even talking about the molecular features.
Well, we're not talking about grade.
With a PET CT? Doesn't that help to indicate grade?
Yes. So the answer to this, my oncologist said a PET CT will not change how they treat us.
Right.
So if you go in and your oncologist is saying you're grade 2 and he's going to treat you with a certain protocol, and you go in and the PET CT shows that you actually have other tumors that the MRI and CT did not catch, then, and they're in distal organs, then all of a sudden you're grade 4. And that means that the drugs they're going to give you, if you're grade 2, are not going to be the same as grade 4. So a PET CT typically changes the grading in most cases. We've seen the grading go both ways.
Yes.
We've actually seen, we've seen cases where patients have been treated based on a CT and an MRI for, lung cancers, and they've gone through harsh chemotherapy and the tumors weren't responding to it, and they were told, you've got literally, 8 months to live. And when we got that patient a PET CT, we found out that they never had cancer in the first place, and that it was a benign lump that the doctors were treating. So we've seen that. We've actually seen doctors targeting metastatic deposits that were not even metastatic. They were just benign lumps, and they've been targeting with radiation.
And we've also had the contrary too, where people are told that it's not cancer, it's just benign, and go practice some relaxation methods.
Unfortunately, that is more common. I just wanted to say that yes, this is how you respond to your oncologist. It's going to change my grading potentially, and that's going to change my treatment. Yeah. So it will change how you treat me, based on grading. Right. Now, it's also going to change how you treat me based on the fact that it's a real-time analysis and it doesn't require serial imaging. Therefore, we can get results right away. We don't have to wait 4 months while you put me on this expensive drug to find out if it's working and the tumors have grown or shrunk. You can find out in 1 or 2 PET CTs over a period of 6 weeks now, and save a lot of money on that drug if it's not working, or keep providing it with confidence. So it's going to change your grading. That's going to affect how you're treated. It's going to change how you respond to the drugs and how you determine if you're responding to the drugs by providing real-time information versus having to do serial imaging. And then it's also going to tell you if you're getting a complete response versus a partial response. Or no response, obviously. And that's based on individual SUV variations. So let's say you get a CT scan and none of those tumors have changed at all. The doctor says, well, you've got RECIST criteria, stable disease. Then you get a PET CT and you say, hey, wait a minute, the tumor on my leg has gone up in SUV. It was 14, now it's 28. And all of the other tumors in my, breasts have gone down. And, they are now, 2 and 1. So now you can just cut out the tumor in my leg and you don't have to irradiate my breast or give me further treatment. So by looking at individual serum uptake values of individual tumors, that will change how you get treated. Because then maybe they can switch to a different drug or a different approach to treat the tumors that are not responding. or have confidence that the drug they're treating you with is responding, or certain tumors are responding to that. And then the fourth way that a PET CT will change how they treat you is with pseudoprogression. So when we first started giving immunotherapy to patients, as I mentioned, 30% of patients get pseudoprogression, up to 30%. And their tumors will grow and expand. And so it was quite interesting in the beginning of the nivolumab and pembrolizumab trials, where they would give these patients drugs, and these patients their tumors would expand, and then new tumors would pop up out of nowhere. And those new tumors popping up out of nowhere were actually just micrometastasis that were too small to be seen on a scan. And then once the immune system went inside of them, it blew them up. So they're now at a much larger resolution or size, and the scan was able to pick it up then. So it looks like they got new tumor growth, but really it's just a tumor that's much bigger because of the pseudoprogression. So a lot of these patients were taken off these drugs and told that they weren't responding, and we've got nothing else for you. And then, years later, these tumors call up their doctor and say, hey, doctor, I'm feeling pretty good these days. And the doctor, what? You're still alive? You're still here? How did that happen? Come in for a scan. We want to know what happened. And so then we started seeing that pseudoprogression was something. So pseudoprogression and PET CT, as I mentioned earlier, is a tricky thing. Pseudoprogression can be used for brain tumors because often brain tumors, that may or may not respond to treatment. Pseudoprogression is a good way of seeing if that is necrotic tissue. So pseudoprogression a PET CT will only determine pseudoprogression after the immunotherapy has finished its job. So if it's actively causing tumor or infiltration of TILs, CD8 positive tumor infiltrating lymphocytes, then it's going to look hot on a PET CT. But once that tumor is dead and the immune system is not attacking it anymore, it may still be the same size tumor, but then the PET CT will tell you that. It will tell you this is necrotic tissue, it's dead, it doesn't have any SUV value, therefore it is a dead tumor and you have responded. So once again, a PET CT will change the way you get treated based on its ability to determine whether pseudoprogression has occurred.
So that's kind of a timing factor then.
It is. It won't determine pseudoprogression in the process of the activity, but it will determine it after it's happened.
And you might have touched on this briefly because you said, okay, how will a PET CT actually change my treatment? Again, we said 87.5% of the time, the statistics of the cancer agency show it absolutely changes the treatment because it changes the grading. It changes.
Gives you real-time versus serial imaging, tells you individual SUV values, and it's able to detect pseudoprogression after it's occurred.
Right. So one thing you didn't mention, but I can only imagine it's a significant factor, is a surgical perspective, where because of the accuracy of this scan and how well it detects what is cancer and what isn't.
Good point. Yes.
Even if you're going to go have a biopsy taken, say for genetic testing, you want to make sure you get a good sample. A PET CT makes sure that the surgeon is digging in the right place and getting the right tissue.
Yes, so we do see that a lot. We see surgeons doing biopsies of benign tumors because they just didn't read the PET CT that was even done.
Yeah. Okay,
so,
oftentimes it isn't.
Oftentimes it isn't done, and they get a inconclusive biopsy.
Yeah.
So definitely PET CT. It should be your initial part. And if a doctor tells you that it's not going to change the way you're treated, you educate.
Yes, send them a link to this video because there's lots of reasons.
Or just repeat those points, yes.
Yeah.
And so, sorry, I'll have to write in biopsy accuracy. Thanks for bringing that up, Michelle.
I do. Yeah, you're welcome. I just know that
Surgical
surgery,
options,
that does make a big difference. And a lot of times once you may have been told that your tumors are inoperable, but following up your treatment with a PET CT, you might actually see, wow, because I had genetic testing, I got on the right treatment, my tumors have shrunk
so much,
and now it is operable. We've seen that happen.
We do. You see that? I just saw that the other day, actually.
So everything that Alex has talked about today, all the diagnostics, and then all of the research and looking into the most current clinical data, they can all be used, in various time spaces in kind of a cyclical fashion. And that's why, one of the things that I hear you saying often, and that the ASCO post is echoing, is that cancer is quickly becoming a if not curable for everyone, a chronic but manageable disease, because you can just continue to use these diagnostic tools and these targeted therapies and immunotherapies to respond appropriately to what's happening in the moment in your body.
Thank you for watching Cetome TV. Subscribe below and stay informed.